research with us as she can. So thanks everyone for coming to the NOVAFRICA seminar. I'm Wayne Sandholz, and we are thrilled to have Anne Caring here from Princeton to present her research to us. So without further preamble, I'll just turn the time over. Well, let me just give the ground rules where we typically have, it's a bit flexible. We typically have 60 minutes of presentation with a normal econ style of questions during it. And then we typically reserve about 15 or 20 minutes at the end for Q&A beyond that. And so anyway, that gives us buffer for you to be a bit flexible with how you want to structure the time. Anne. Sorry, go ahead.
No, I'm very happy to be here. I was just about to say I'm happy to be flexible for people to ask questions along. And then I think I anticipate an hour and a half. If we can do an hour 25, I just need to run off 5 to 4. But I'm happy if people have more questions or we go longer. I have a few slides at the end about follow-up research we're currently having in the field. But I'm happy to go with the flow and answer questions from the beginning, especially if there's any confusion.
Okay, wonderful. Well, in that case, let's jump right in and I'll turn the time over to Anne. Thanks, Anne.
Okay, thanks so much, Wayne. Well, I'm really happy to be here today. I had a great morning so far. It's been incredibly interactive and had a great time learning about everyone's research. So today I am presenting work that I, with a large team of researchers at Innovation for Poverty Action and a number of brilliant RAs have done in Sierra Leone during my PhD. And it's my job market paper back then. It's submitted now. I would love to present to you the follow-up work on this, but it's still in the field due to COVID, was slightly delayed. But I think this will hopefully either way be interesting, particularly in the time right now where we're trying to roll out globally a new vaccine. So the paper is titled Social Signaling and Childhood Immunization, and it's an experiment that I ran in Sierra Leone. So the paper is motivated broadly by the fact that individuals take actions, visible actions, to influence others' perceptions of them. And these actions might actually be costly often. So we have recent field experimental evidence across a domain of important behaviors such as voting, the decision to make charitable contributions, or even to exercise effort on tests that have shown that people take these decisions in light of social image concerns. So they might be able to take certain actions that even contribute to public goods if there's a presence or visibility of their actions. However, there's a general lack of evidence, and I think we just actually discussed this in a podcast, of how we can harness these social image concerns to promote good behavior, and also how to do so particularly in a low or middle income country settings, where other structures that might be prevalent in high income countries, such as laws, your child can only enter kindergarten if it has all routine immunizations, or other sort of more formal mechanisms that we have to enforce certain behavior are not present or too costly, but we may want to retreat to certain informal mechanisms and build on social norms. The second thing that this paper is doing, it is trying to look at the effects of social signaling in a dynamic setting. So most existing literature is looking at how social image concerns or social signaling concerns can influence a decision in here and now in the present, as these sort of social image concerns, or sorry, let me precise, reputational returns, benefits, or costs are materializing as well immediately in that moment. But we know much less about, or there's no empirical experimental evidence on how these social signaling concerns may play out in settings where people dynamically take actions over a longer course of time. The second motivation of this paper is actually, it's an empirical observation. So if you were to take a random subset of countries, low-income countries from the Demographic Health Survey, and we were looking at their vaccination rates, you would witness that vaccination rates across a large range of low-income countries are still too low. So while we've made a lot of progress in the last 2 decades on increasing access to vaccines, which we observe in the data when looking at children who receive their first immunization in their first year of life, we observe almost universal take-up of rates of over 90%. When we look at the share of children that actually completed our recommended vaccines under the age of 1, we see that a large share of those have dropped out and observe immunization rates that are more likely to be around 50–60%. So why do we as economists care about this? Well, we care about this, I would say, from two points immediately, which is, on the one hand, immunization is one of the most highly cost-effective interventions that we have at hand to improve child survival. And we know that reducing child mortality not only has the benefit of decreasing the chance of a child dying or a child falling sick, but it has a lot of economic knock-on effects for a family in terms of cost, for a woman in terms of having to bear another child, in terms of fertility rates. There are a lot of benefits that are basically emanating or following if you're able to reduce child mortality. The second point is, from a social planner point of view, is that we would want to promote this behavior since there are large externalities from immunization. So I want to preempt before going into further detail in this talk that we're talking about a context here, and this is the case I've observed this as well in working in Uganda and Pakistan. I think it's also recently been the case in high-income countries before sort of the COVID pandemic really took off, that people generally lack an understanding of externalities. So even the health externalities that emanate from vaccines, and they generally consider it as a private decision. That is also the case in the context that I'm working in. But what is the case when talking about these routine immunizations in most countries at this point, given this has been a very established sort of health technology, people consider it that a good parent should vaccinate their child. So we're looking at a behavior that is fairly established where certain social norms have formed around. And then the last point, I think that's very important to point out here, vaccine decisions, however, are currently imperfectly observable. So taking these motivations together, I'm asking in this paper, can we increase timely and complete immunization by allowing parents to show to others that they vaccinate their child? And since I'm doing this in the context where I'm working with the government and we're implementing this intervention at a large scale, I'm also asking how feasible is the implementation of a social signaling incentive at scale. The second and more general question that this paper is trying to answer is, how well do the mechanisms and predictions of the theory of social signaling map into a dynamic in real-life setting? And how much do individuals, in this context parents, value social signaling that they're good parents? So how strong are basically these kind of preferences if they exist? In order to do this, there are a number of things that are fairly challenging and that I'm trying to basically overcome or tackle on this paper in order to answer these questions. So let me just lay out what are sort of the main components in this empirical exercise. So the first thing that I need to do is we need to introduce a signal, because people essentially need to learn about others' actions. So we need to reduce the existing information asymmetries and introduce visibility in actions. And in the second step, they need to attach types to the specific signals they observe. What I'm doing in this paper, I'm making health behavior visible through colored child bracelets. I apologize, normally I would show you these colored child bracelets, but I got mugged 2 weeks ago. My bag got stolen, and that bag included the 2 bracelets I normally carry with me always. So, and I haven't actually had a chance to replace them. I now remember because I don't have them next to me. The second point, what is very challenging when we're thinking about social signaling concerns and introducing visibility in behavior, there are a range of alternative theories that could lead to behavior change as we're introducing visibility in people's actions, such as we can think about increased salience, reminders, or even social learning. So very plainly, in the moment where you are able to observe my behavior, so this might trigger social image concerns or social signaling concerns, I am also going to be able to observe your behavior. And since I'm not going to explore this in a static setting where everyone is moving at the same time, but babies sequentially need to get vaccines, I can basically observe others' behavior, and all these other mechanisms could be triggered and potentially change people's decisions to vaccinate. So what I'm doing in this paper, in order to really hone in on the social signaling mechanisms, I'm designing an experiment and tying it closely to the theory of social signaling proposed by Bonneau and Chirol. And I'm exploiting the fact that childhood immunization is a context where individuals have to take multiple actions. That allows me to do what other empirical research hasn't done as such, which is I can introduce different signaling treatments where I can basically control for these alternative mechanisms through signals that have a different informational component. And I think this will become very clear once I show you the experimental design. The third component, whenever we want to talk about signaling concerns, we essentially need to create common knowledge. So the unit of treatment can't be an individual. It can't be that a signal is in any way informative if only certain people have access to it. So this is going to be an experiment that we're implementing at a large scale. 10% of Sierra Leone government clinics were part of this experiment, and we implemented it over the course of 22 months. In total, this comprised approximately slightly over 38,000 children were part of this experiment. And then lastly, since there are a lot of development economists in the audience, this is obviously a very subtle behavioral intervention. So this is a paper where an experiment where we basically working in a setting that is institutionally very weak and also immediately post-Ebola, and basically wanted to make sure that this intervention is as best as possible implemented, given how subtle it is, and collect high quality data. So what was part of this experiment, but is not part currently in this paper, is we also designed a low-cost monitoring and incentive scheme for government health workers to ensure that this intervention was actually appropriately, correctly implemented. However, I should just, I think, preempt not high-powered incentives. We're talking here about, something like a mobile top-up, where we would give them every 2 months mobile credit in the value of about $2. So nothing major that we bribe people into implementing this intervention. And follow-up work we're having in the field right now is also more closely assessing how valuable this intervention was actually to government health workers in their objective to achieve higher immunization rates. So let me give you a brief preview of the results. I'm going to be showing you in this paper that individuals use the bracelets to learn about children's vaccine status, and they judge parents based on the actions they observe. Secondly, they value this opportunity that we introduced of making vaccine behavior visible and showing that their child is vaccinated. Full and timely immunization rates increased from 56% to 70%. The behavioral responses that I'm observing in this paper are consistent with not a standard model of social signaling, but one where we're allowing for uncertainty. So there is a twist that I'm going to show you in this paper where I'm allowing for uncertainty to be factoring into decision making. And this is the behavioral pattern we're observing in the data that fits that type of model. One caveat as well, in the results, I'm observing smaller impacts of signals if the action that is signaled, that we're allowing people to signal, is less valued. So basically not all signals are the same, and we carefully have to think about at which margins we're introducing visibility and how that might alter behavior or may not alter behavior. And then lastly, the value of social signaling is equivalent to approximately 5 to 8 miles walking distance from clinics. So the major cost factor that I'm looking at in this paper is that people have to walk to the clinic, and I'm using that to price out how much people value signaling. To put it more into context, this is about equivalent to an additional 1.5 to 2 vaccines that basically people would be willing to acquire. So a quick overview of the talk. I'm first going to give you a little bit more context on the empirical context information. Then secondly, I'm going to step into the theoretical framework. This is an experimental design. I know it differs depending on how things sort of come about, but this is really work that was initially motivated by the theory. A lot of simulations and design thinking went into it, and then only later the experimental design actually became solidified, or I found it out. So I'm going to start off with the theoretical framework that really motivated the design, but also will give you a sense of why I'm collecting certain data, like which variables I basically collected in the field. Then the experimental design. Fourth, I'm going to structure the results in 2 sections to speak to the theory. First, the mechanism designs, and secondly, the main outcome. And then lastly, depending on time, I'll also show you how I've added some structure to this problem to actually quantify social signaling concerns, like how strong are these preferences to put an actual value on it in a dynamic discrete choice model. Are there any questions at this point? Otherwise, I'll just move on.
And so do you have a sense of how much of a social norm is to vaccinate children to begin with? So in another way, so is your experiment going to have effects on the norm itself, and not just on the use of the norm?
Yeah, I can answer this up front, and I'll show you data at different points. There will be some data I'm showing you on this slide, and there will be some data later that I collected at the end line. To answer this question, this is from what we've learned from the data so far, and over the course of sort of 2.5 years of this experiment being implemented, these signals worked based on existing norms. And there are strong existing norms around immunization that we would see in the revealed preference data, just simply, I think, in take-up data, but also that we're seeing in sort of stated perceptions from households around immunization. And I do not observe any shift in people's perceptions around the importance of certain vaccines. And so there's no evidence that we're having in terms of any social learning happening. But I think what I can't quite quantify to you, I can't speak to what I won't be able to say in this paper yet, to be precise. I think it's sort of like how we're thinking about social norm change happens and how we're able to pick up the social norm change. And one thing I think is that people are changing their perceptions around how important a certain behavior is. And this can be through learning just as a first stage, sort of like we're sending a signal, they're thinking, oh, this is more important than I previously thought. There was some uncertainty around this and they update sort of their posterior belief it's more important. I don't see anything in that. But another way I think what we could think about is that just generally, what are the actions that people draw from in order to assess whether a person is a good or a bad parent, sort of the salience we're creating around different actions. This paper is not going to be able to speak to like a comparison of saying, oh, are people now more likely to draw on immunization behavior of parents versus like breastfeeding behavior or other things that they're sort of prioritizing as they're thinking around making social norm judgments. But this is sort of an avenue I'm trying to explore in the follow-up data collection. But the first part, which is purely looking at people's preferences of how important they perceive a certain behavior, we don't see any changes. Does that make sense? Okay, so let me briefly explain the context and also give some more information that is speaking to the question that Pedro was just asking. So the most important piece of information I need to keep you in mind for the rest of this talk is that a child under the age of 1 needs to complete 5 immunization visits. The first visit is at birth. The second visit is approximately at 14 weeks, 1.5 months. The second and third visit at 2.5 and 3.5 months. And the last 5th visit is at 9 months. Importantly, these vaccine visits cannot be bunched. So the 3 vaccines that you see in the middle, if you just shift your focus onto the slide, you see DTP1, DTP2, and DTP3. This is similar to the COVID vaccine. This is essentially a vaccine that is composed of multiple vaccines, so diphtheria, tetanus, and pertussis, but it's also a vaccine where a child requires multiple dosages in order to receive full protection and also for overall to reach herd immunity levels. Importantly also to preempt, since this is a paper that is focusing on encouraging or increasing demand from parents and not discussing the supply side, as most of you probably aware of, Sierra Leone is one of the 18 poorest countries in the world. Remarkably, however, the supply side of vaccinations is working really well. So there's been large investment made over decades from international funders and governments in order to make this working. Vaccines are free at government clinics. We observe very few out-of-pocket payments and more sort of in terms of giving a gift to the nurse. Also, these immunization services, different to what has been described in other papers in India, are actually offered at a very regular basis, either weekly or monthly. And it is an existing well-established technology to the extent when we were asking as baseline communities, 94% of communities knew that a child needs to have requires 5 vaccine visits under the age of 1, and also the purpose of vaccines to protect against diseases. Then speaking to what Pedro was just asking, when asking at baseline, what do you think is the main reason or what are the reasons why parents are not timely or fully vaccinating their children? The primary reason that was named by 79% was negligence of parents. So the perceptions of communities are such that the main reason why parents may not bring their children to the clinic on time or, very late or not at all is because they're negligent, they're careless. The second and third reason were travel distance and that they have a lack of information. However, those 2 reasons had a share of less than 40%, around 34% of individuals that were mentioned those reasons. So really strongly standing out is this perception of parents just don't care enough about their child's health. Pedro, is this sort of answering the question for now? Okay.
Yes,
Wayne?
thank you.
And yeah, I wanted to ask, what's the baseline rate of infection and deaths of these diseases? I mean, is this a context where there's herd immunity enough that not many kids are dying of these diseases, or is there enough of it that you're actually going to be able to pick up health outcomes, as outcomes of your intervention?
So I can immediately preempt this. As part of my PhD, I did not have the funding to measure health outcomes, and there isn't good enough administrative data in any way to measure that. So if you were to think at administrative records, they just primarily record malaria or typhoid incidents or diarrhea, which could be linked to any types of diseases. The thing that has been collected or has been tried to collect a little bit more frequently since the Ebola outbreak has been measles outbreaks. and there are recurringly measles outbreaks. So I would say, and this also is going to sort of, this is going to be consistent with the data that I'm showing you in preferences over the measles vaccine. The measles vaccine is something that's very much on the forefront of people's minds, sort of the 9-month marklet, they would refer to it, because there are outbreaks. However, one of the leading childhood killers in this setting is respiratory illnesses and diarrhea. And there is the rotavirus vaccine that has been introduced before I started this intervention. And actually the rotavirus vaccine is part of this package of 3 vaccines in the middle. I didn't write it here, but it's part of the DTP. So the disease incidence is high, maybe not mortality, but certainly morbidity. The data on this is fairly bad, and that's something that I have been able to measure as part of this intervention. So this intervention is going to focus on take-up and specifically also on timely take-up, not just did you ever come. Okay, so then let me...
May I just ask a question?
Sure.
Any of these vaccines is included in a vaccination campaign door-to-door?
Yes.
Or?
Yes, absolutely. So measles is included in the vaccination campaign. The ones in the middle are not included in the vaccine campaign because they need to be given at a certain time. Sometimes they do default tracing, but measles and also polio is included in vaccine campaigns. So the data that we are collecting, just to be clear, so I am collecting data in this paper. We did ask in the main data when verifying immunization take-up of individual children, whether they received the vaccine at a clinic or whether they received it at outreach or campaign. The share of outreach and campaign in this paper, in this data that I'm using here, is very, very low. So I think it's below 5%. Generally speaking, also, if a person had received the measles through campaigns are nationwide, obviously implemented, as you know, so it's going to be the same across my control and it's going to be the same across my treatment, and it wouldn't necessarily lead to timely immunization because they would just get the vaccine at the point when the campaign is. Is that sort of where you were going, or is there any other concern that you had related to campaigns?
Oh, it was exactly about supply and
demand. Yeah, but I think I should add something on, because I think I'm like bringing a lot of reasons in why people are extremely sort of focused on this measles vaccine. Just to be clear, a lot of work has been done by governments, including the government of Sierra Leone, in trying to increase the completion of these 3 vaccines in the middle. As I said, whooping cough is in that, rotavirus is in this, which is speaking to respiratory illnesses and speaking to the incidence of diarrhea. And they have been, for example, giving out bed nets. So there is a campaign where people, or not a campaign, at a clinic, when you have completed all 3 vaccines, you would be given a bed net, all the 3 vaccines in the middle. So there's been a lot of focus on how we can get people to finish this series of 3 vaccines in a timely and complete manner. But, you know, with varying degrees has worked or has not worked, sort of. So it's not something that the government hasn't been pushed for, or health workers haven't been pushing for in terms of making it salient to people. I will move on unless there are any other questions on the specifics of this context. Okay. So now let me jump to the theoretical framework. What I'm going to be doing is I'm going to immediately map the specific decision problem into the theory provided by Winterborn rule. And then I'm going to use simulations to show you the predictions of the theory of social signaling, contrasting what they would look like in the standard model without uncertainty and what these predictions look like if we allow for some uncertainty in decision making. So the way I'm going to think about this is very simply, when looking at individual preferences, if you first just focus your attention on the red part, an individual parent has to make a decision to take their child indicated by AI for 0, 1, 2, 3, 4, or 5 vaccines. And there is going to be a certain benefit that emanates from taking your child for these vaccines. And part of the benefit, and that is really the only heterogeneity that I'm considering in this model, is going to be your type. So your intrinsic motivation to look after your child's health. So the assumption here is that people who have a higher type are on average going to have a higher valuation for immunizations compared to a lower type. Then the cost, there's a cost from immunization. I'm going to be thinking about this in this problem as walking to the clinic. So we're going to think about people having to walk a distance between 0 and 5 miles to the clinic in order to obtain a certain vaccine. So when now introducing social signaling concerns, what essentially happens is in the utility function directly entering in are the expectations indicated if you now look at the red part by capital E of others indicated by _I or negative I. So what enters into people's utility function is now the expectations that others are going to form about my type V, which is otherwise normally unobservable. I should have mentioned that. So my type of how much I care about my child's health is obviously as such unobservable. I can only observe the actions that a parent takes. And these expectations are going to be formed conditional on the actions that I take, in this instance, on the number of vaccines that I'm going to be taking my child for. You see a letter R here. So what I want you to think about in the following is that you can observe one of two things. R is going to be the threshold. So R is either going to be 4 or 5 vaccines. And you're going to be able to observe whether a parent has taken their child for 5 vaccines or fewer than 5 vaccines when it's less than R, or that you're going to be able to observe whether a child has received at least 4 vaccines or less than 4 vaccines. So while the decision space or the action space is like 6 separate actions that you could take, I mean, between 0 and 5, I'm going to think about the type space, sort of the expectations that others are going to be able to form about sort of like there's going to be 2 different expectations they can form, like a binary split, which is going to be either you took your child at the threshold or above the threshold, or you vaccinated your child below that threshold. So what else, in addition to sort of this expectation term, the expectations of others that are now going to enter into my utility, other relevant objects here or parameters, let me briefly walk through these, which I am considering going to be important in the empirical exercise. So you see lambda. Lambda is the parameter we're thinking about as the general value that you assign to the expectations that others form about you. It's basically your social image concerns, lambda. And then there's a second parameter indicated by omega R, which is going to be, which we're going to think about as the social desirability of a specific action. So for example, you might care a lot about how others perceive you as a parent, whether you're a good, generally have very high image concerns about the expectations that others form about you, but not all actions are equally valuable to you. So for example, you might value, there's a lot of social desirability attached to breastfeeding your child if you're a woman, in terms of being judged as a good parent, but you may not gonna value, what's not relevant to you is whether your child is wearing like pink or blue shoes. That is an action that's not really socially desirable, or an action that is valued when we're thinking about social signaling concerns for yourself. So in that instance, an action of signaling 4 versus 5 might be differently valuable to you when thinking about how others might assess you. There are different social desirability concerns attached to these 2 actions. And then lastly, there is X indicated here as the probability of vaccine decisions. Basically, others are able to observe your action, and that is something that I'll be able to experimentally manipulate in addition to R, the cutoff. Are there any questions at this point in terms of the model? Otherwise, I'm going to go to the predictions now. Okay. So if you were to ignore social image concerns, basically this is a very trivial optimization problem where a person chooses the optimal number of vaccines depending basically on their type VI. And what I'm doing here is I'm showing you a graph where I am plotting the data from the control to show you what vaccine levels look like actually in the control data. And I'm going to, it's simulated. The reason why I simulated is because what I'm subsequently do is I'm going to add on social image concerns to show you how the predictions of the model would vary if you were to allow for social image concerns. So also I'm going to be using this graph a lot, so bear with me for a moment, please, to just explain what I'm plotting here. So what I'm doing here and subsequently is on the x-axis, I'm plotting the 5 vaccines. So you see indicated vaccine 1, 2, 3, 4, 5. Just going to refer to them as that and not the names to ease the load of remembering health information. And on the y-axis, I'm plotting the share of children that are vaccinated for a specific vaccine. So I'm plotting the cumulative distribution here. So what we can see if you look at the first vaccine, and this sort of speaks to Pedro's questions as well, 96% of children in the control group actually received the first vaccine, which speaks to that the supply side is fairly well functioning, but also generally that people are fairly pro-immunization, that there aren't like large shares of anti-vaxxers who just generally don't want to come for immunization. Then what we observe as we're moving to the second, third, and fourth, or just generally down sort of the number of vaccines, there is a steady decline. And the largest decline is from the third to the fourth vaccine, and then from the fourth to the fifth vaccine. meaning at those margins, there is a strong opportunity for introducing visibility, as it would allow people to separate themselves from those people who got stuck, for example, at vaccine 3 or who got stuck at vaccine 4, and to show that they actually made it to the next vaccine. So we're now solving this problem. We're now thinking about the optimization problem in the context of social signaling. What is going to happen is that people will think about, obviously taking into account all the actions that other people will do, and sort of we have a simultaneous problem that people are going to solve, technically speaking, through a fixed point of like these reputational returns. So in terms of trade-off, the way to think about this and also is solved through simulation, there's going to be a person who has their privately optimal action. Let's say they want to come for 3 vaccines, just to explain this very plainly, and now they have an opportunity to signal to show that they come for 4th vaccines. If they were to deviate to 4th vaccine, they would get that social signal that allows them to show, actually, I came for 4 vaccines. So specifically, obviously, from a private benefit of point of view, this would be suboptimal to them because they privately optimally would have chosen 3. And if they were to come for 4, this would give them a negative net benefit. However, the red term now is what's really important, is the reputational returns. And it's exactly sort of the difference that wedge between the average type based on the observed actions they take, like either coming for 3 vaccines or coming for 4 vaccines. So A star I is their privately optimal actions, and A S star is basically the social signaling action, I mean, where they would have to deviate, is sort of the wedge that is opening up in terms of the difference in the expectations that others are going to form about them, taking one versus the other action. And so we're going to achieve a new equilibrium if it is the case that, first of all, this difference in expectation is greater than 0, but also in addition to that, we need to actually be the other terms, which is the social image concerns and the sort of social desirability term of this for the specific action to be greater than 0. So what I'm going to be testing with the experimental design is going to be whether these social signaling preferences overall, all these 3 things combined, these 2 parameters and the difference in expectation is overall greater than 0. So returning to the image that I just shown you a moment ago, okay, I have time to, Wayne, how much time do I have? Sorry, because this is always the moment where I should check on how slowly I'm going.
No,
I have
you're
time
fine.
to, okay.
You have, yeah, you're doing fine on time. You have at least 25 more minutes until you hit the 60-minute mark, and then, you know, up
people,
to
but
like
people
20,
are already
25.
asking questions, right? So I can go a little bit more. Okay, I'm just
Of course, yeah.
Okay, so now I'm going to return to the image I just shown you. In the blue line, which is sort of covered right now here, I had previously plotted you what the level of immunizations look like in the control group. Now, what I'm going to be assuming here is exactly, let's assume we were to introduce a signal at vaccine 4, which is indicated by the green line. And then the other thought experiment we can do is, let's assume I were to introduce the opportunity to signal that you came for the 5th vaccine, which is indicated by the red line. So very simply, probably as you predicted, on the margin where you're able to signal that you took a specific action, we have a discontinuous increase in utility. So more people are likely to take that action because they get the additional benefit of being basically considered, you know, the higher type. And importantly, if you focus your attention on the signal at 4, we don't see any shift. However, in the standard model, static model, we wouldn't expect an increase when you look at the green line for the 5th vaccine. Basically, based on the premise that you can signal now that you came for 4 vaccines, but there is no incentive to vaccinate any further because you can't signal that you came for 5 vaccines. Another important part to consider when thinking about the predictions of this model, we would expect a certain bunching prediction directly at the action where we're introducing a signal. So we're allowing parents now through a signal to show that they took their child for 4 or 5 vaccines. But we wouldn't observe any shifts in the earlier part of the distribution, only if it were the case that these signaling concerns are particularly strong. So people strongly care about that. In this model, we would observe, if you focus on the green line, that anyone who previously came for 3 vaccines would now come for 4 vaccines, which is indicated by the fact that the share at 4 vaccines is the same as at 3 vaccines. And only then we would observe to see shifts in the earlier parts of the distribution. So people from earlier parts are sort of coming in. Only once everyone who previously got stuck at 3 moves to 4, we would also observe in theory people moving in from earlier parts of the distribution. So these are the predictions if you were to take the model as it is right now. However, as you can probably anticipate, there is one very strong assumption, which is what we've talked about right now, and it's the model you normally use for static decision making, is that a person ex ante has all the information necessary to basically at birth make the decision whether to take their child for 3, 4, 5, or even only 2 vaccines. What is much more likely is that there is certain uncertainty about future costs or preference shocks. And while a person may know the distribution of these shocks, they only know about the realization of their specific shock in the period where they may need to make the decision. So to be clear, if a mother is planning on taking their child for 4 vaccines, she arrives in the period where the 4th vaccine is due, it might be the case that someone in her household has just fallen sick, or there might be a specific opportunity coming up for her to work on her farm, which is going to change her decision on whether to take your child for the vaccine. So I think in terms of sake of time, let me move through this, but all I'm doing here right now is I'm basically transforming the decision-making problem for one where one decides ex ante to take 0, 1, 2, 3, 4, 5 vaccines into one where a person decides in every period T, and there are 5 periods now, whether to take their child for a specific vaccine. And what is important in that calculation, how it alters the decision-making problem, is when the person decides in a specific period whether to continue vaccinating, they're also forward-looking to consider what is the option value of, if I vaccinate my child in this period, what is the option value I'm going to hold for future vaccination. So this is particularly when thinking about, am I going to take my child for the 2nd vaccine or not? And I have a cost shock in here and now. I'm not just going to consider that cost shock, but I'm also going to think about the option values. For example, am I going to be able to signal in the future? Am I not going to be able to signal in the future? So this problem can be solved by backward recursion. And what I really want to show you right now is how actually the predictions change if we're just allowing for the simple type of uncertainty in a model of social signaling, and where we actually might be moving closer to what is happening in the real world. So on the left side, I'm showing you the graph I had shown you before, which is the predictions that we would get from a model of social signaling without uncertainty. And on the right side, I'm now plotting, making the same parameter assumptions. What would be the prediction of the model if we were to allow for the type of uncertainty I had just described to you? So what you can see is the predictions are much smoother, sort of the Stark bunching prediction goes away. And you can further also see that we have shifts from earlier parts in the distribution where people are starting to deviate from their privately optimal action, might be coming now for 2 or 3 vaccines, and previously they came for less, but they may not make it all the way to the end because they're optimally going to be able to adjust in every single period as they're going to learn about their personal private cost and preference shocks. And then also an important part, what sort of alters the predictions of this model is if you look again at the green line, where I had previously shown the sort of Stark bunching prediction at 4, if I were to give you the opportunity to signal at 4, we also would predict that some people would now come for 5 vaccines. And that is purely based on the fact that a signal would move more people to 4 vaccines. And some of these people may experience a positive cost shock, so they just naturally get knocked over and are also more likely to come for 5 vaccines compared to the standard model. If there are no questions right now, please tell me if there are any questions at this point, if I lost anyone. Otherwise, I'm going to jump into the experimental design, how I'm going to think of testing these predictions. Okay, I either lost everyone or everything is super clear at this point. So I'm just going to keep going. So I'm going to talk about, what? Sorry. Yeah, okay. So let me go in how I'm going to test this. So in this experimental design that I'm showing you, on the top, I'm plotting the 5 vaccinations, and on the left hand, I'm plotting you the 4 intervention groups that I'm going to have in this experiment. So first, we're going to have a set of clinics. I'm going to tell you about the unit of randomization in a moment, but essentially it's going to be clinics, where when you come for vaccination with your child, everything is going to be as usual, and there's going to be no signal or bracelet. Then I'm going to have a first signaling treatment, which is clinics that I'm going to refer to as signal at 4 clinics, where when you come with your child for the first vaccine, you're going to receive a yellow bracelet, and that yellow bracelet is going to say first visit. As you come back for the second and third visit, you're going to keep that bracelet. When you come for the 4th vaccine, that yellow bracelet is going to be exchanged for a green bracelet. And when you come back for the 5th vaccine, you're going to get another exchange, but it's going to be for the exact same bracelet. So essentially, you have an opportunity in this treatment to show at the 4th vaccine that your baby received that vaccine. And on the 5th vaccine, you're going to be stuck with that signal. There's going to be a second signaling treatment, clinics that I'm going to be referring to as signal at 5, where your child also gets at the first vaccine visit a yellow bracelet. It's going to keep that bracelet for the second and third vaccine. At the fourth vaccine, that bracelet is going to get exchanged for a yellow bracelet, but it's exactly the same bracelet as you had originally. And only once you reach the fifth vaccine, you're going to get a green bracelet that says fifth visit. Now, if you were to take these two signaling treatments, then as I already sort of alluded to in my intro, and we were to compare them to the control group, there's all sorts of other plausible mechanisms, such as people might value the consumption value, or they might just like the bracelets. They basically assign a consumption value to receiving a bracelet or getting a bracelet exchange. Similarly, there's obviously now reminder aspect as bracelets are popping up. So the appropriate control that I'm introducing in this experiment, I'm going to be referring to as uninformative bracelets, where when a parent comes to the clinic for the first vaccine visit, they're going to be given the option to choose between a yellow or green bracelet, so they can pick their favorite color. They're going to keep that bracelet at the second and third visit. At the fourth visit, that bracelet is going to get exchanged, but importantly for the exact same color. And the same as at the fifth visit, this bracelet is also getting exchanged. So you're probably asking yourself, why are all these exchanges? Well, this was a very it was meant to be a very good behavioral experiment where we're holding everything else constant and really eliminating all confounds. So the important thing is, first of all, if you were to compare signal at 4 and 5 to the uninformative bracelet, it is now the case that everyone generally has access to a bracelet. So we're holding the consumption value of receiving a bracelet constant. Similarly, I'm holding constant the exchanges, at what point a mother gets the opportunity of receiving a new bracelet. Also, any salience or reminder effects that would result from these bracelets popping up in the community are mimicked in the uninformative bracelet. And then lastly, there are probably, you may say like, okay, that's all great, but what about, for example, social learning? So one of the big concerns that I had in this experiment was essentially that people might, and Petro also just alluded to that, what if it's the case that people are sufficiently uncertain about their about the benefits of immunization, particularly since it was in a post-Ebola context? We launched this experiment just about 7 months after Ebola was officially declared as ending. What if actually introducing these bracelets, and something also the government was excited about, could just lead to encouragement because people now know that others are going back to the clinic. So one of the design features here, I'm going to explain you now. I can explain you how I would have tested for this, but I don't need to, as you see in the end, was essentially, given that the signal at 4 did not have a new signal at the fifth vaccine, the test would have been to look at the transition probability from vaccine 4 to vaccine 5. Even in the instance of uncertainty, the transition probability between vaccine 4 and vaccine 5 should not be different between signal at 4 and the uninformative bracelet. If there had been an increase in the transition probability between signal 4 and the uninformative bracelet, that would have suggested that something else must be going on of why people continue vaccinating further, because it cannot plausibly be social signaling concerns, because no one has more information once you move to vaccine 5. Are there any questions right now? There are additional concerns you can have about mechanisms. I have a few more in the paper, but are there any concerns otherwise at this point, or what I can explain on the design? Otherwise, there will be a bunch of data where I'm going to address a few more concerns. Okay, then let me move. So here you see the bracelets that I would normally show you. Just to be clear, they don't look like the regular silicone bracelets that you would normally wear or I would wear on my wrist. The challenge in working with infants or babies is that they're actually growing. So one of the concerns was as a child is growing, the bracelet would no longer fit. So a natural signal would also be sent as the bracelet is falling off or no longer fitting about whether you have come for a new immunization visit, even in the uninformative treatment. So the bracelets were created so that they could be size adjustable and would fit the wrist of a child between the ages of 0 months and 15 months. That's why they look a little bit different. So then this is a map of Sierra Leone. Sierra Leone at the time had 14 districts, now it's 17, there's been some district splitting. But if you look at the map, you see, well, you don't see the districts, but essentially we selected 4 out of 14 districts back then with the government of Sierra Leone, and randomized clinics stratified by district into these 4 different treatment arms that I described to you: the control, uninformative, signal at 4, and signal at 5 treatment. So when saying randomizing clinics, just to be clear, a clinic in Sierra Leone has a catchment area. We're working with clinics that have generally non-overlapping catchment areas. There was a problem with that, but we designed an algorithm such that we would optimally fit clinics into a space and would only implement this intervention in non-overlapping areas. But generally speaking, everyone in the catchment area of a clinic would have access to the exact same signal. So the unit of randomization is clinic level, meaning all communities that were fed by this clinic would be eligible to receive the bracelet. The second component of the randomization was that in the vicinity of a clinic, I selected 5 communities, and 2 of them were at a distance of 0 to 2 miles walking distance to the clinic, and 3 communities were at the distance of 2 to 5 miles walking distance. This is the variation in distance, walking distance, that I'm going to exploit later on in order to quantify the value that people assign to social signaling. So in total, there were 582 communities. This experiment was launched. We had to phase it in between June 2016 and November 2016. It was a big logistical effort. We only had a field team of 12 people, but and 2 field managers, but we made it happen. We trained obviously all health workers in these clinics, in the intervention. And importantly, what I haven't mentioned yet, but in each of these communities, we held an information meeting, including also in the communities that were in the control. So every single community across all 4 intervention arms had an information meeting that would discuss the importance of immunization, any existing barriers. And then in the bracelet groups, in the bracelet clinics, the communities were also talking about the introduction of the bracelets. However, free of any social image messages, just literally saying, when you come to the clinic, your baby will be given that bracelet and then it will be exchanged. Also importantly, I should mention, health workers were trained, and this is also the data that we monitored throughout, to give this information to a parent when they come for the first immunization visit. So the idea is that ex ante parents would know what is coming up. They wouldn't just accidentally get a green bracelet or so on. They were told when they came for the first visit, you're now given a yellow bracelet for the first visit. And if you come back for the 4th or 5th visit, it will be exchanged for X bracelet. Between July 2016 and February 2018, this intervention was basically fully integrated in routine immunization services in Sierra Leone across these 120 clinics. So it was not IPA or any research organization that implemented it, it was the nurses who implemented it, and we monitored it. The monitoring was such that we roughly visited each clinic every 2 months to check on the implementation, the stock, and the record keeping. Then the data that I'll be showing you in the following, the majority of the data comes from a large listing exercise that we implemented between September 2017 and January 2018, where we listed all babies that reside in these catchment communities. And so not only the alive babies, but also diseased, traveled, moved, in order to have a complete census. This is over 14,000 babies. And we collected from those babies immunization information from their growth card and also from memory. Growth card is the card that over 90% of children would have, where the clinic would indicate the immunization visits a child has received, but we also cross-verified that with the memory from the mother. And then lastly, I'm going to show you data where I drew a random sample from this big sample of 1,300 parents, where we did a detailed survey between February and April 2018 to elicit their knowledge, information they have about the bracelet, and importantly, first and second order beliefs about the actions that others may have taken, or what actions they believe others they have taken, and their preferences for vaccines. Any questions? Otherwise, I'm going to jump into the results now.
Can I ask you about these information meetings, to a certain extent, they could convey different types of information, right? For different catchment areas, in the sense of explaining how the bracelet treatment was going to work. So if people are explained that something happens differently for the 4th visit or the 5th visit, that's probably they need to explain why, right? So there is probably a little bit of differing information in the beginning. So I was wondering about whether that has an impact, or can you measure that in any way? so to distinguish from your social signaling?
So I think, so to be clear, all the information meetings were scripted and they were fairly simple and plain. So it would, and I think the important thing is also, I think that in all bracelet treatments, the same exchanges were described. The only difference would be the color essentially for which the bracelet is exchanged, right? So even in the uninformative bracelet, you would receive a new bracelet. The only thing is it's the same color in one treatment. Oh, you're going to get a green bracelet. And in one, it's a green on the 4th and a green on the 5th. In terms of anything that I can measure or that we have measured in terms of people's information about immunization that they have, the visits, the importance of vaccines, how important specific visits are, all of that, and I'm going to show you some data in the following, I don't pick up any significant differences across the different groups. So also not in terms of whether bracelets were handed out by the nurses or help me out in terms of any concerns you have right now specifically, but there's nothing more specific. And I guess if there had been anything, then it would almost be a magic bullet in terms of having one information meeting, given how many information meetings are held by so many UNICEF workers and so on. And I had magically had that impact, right? I mean, we're talking about an information meeting that was with a certain group of people once. To be clear, we did a follow-up meeting again. So we did the first meeting when the clinic was trained. They had never seen the bracelet to let them know what's going to happen, because I was very concerned about rumors. We've seen in the pilot, if you don't explain social signaling treatments correctly, rumors can swirl about eligibility for aid, you know, lots of stuff. We all know that something gets introduced and messages float around. And then we did another information meeting in the community about 2 months after the bracelets have been traced in. But again, the same across all bracelet groups and all control groups. And then, you know, we let it run for 1.5 years or longer and see what happens. And I'm also going to show you treatment effects over time. I should mention one of my research assistants, Jonas Guthoff, he has a companion paper where he's trying to look at, or he's looking at the effect of these information meetings. It's not yet been published as a working paper, but I think we're trying to get it out soon. But there is nothing that would speak to generally differential effects across these different bracelet treatments. However, there might have been some impact in general on information meetings, but overall, like basically also in the control, going in and doing a meeting may have had some impact initially. But that applies to all of them, no differential effects even across control and bracelet.
Thank you.
Okay, you're welcome. And just to be clear, the way he can identify that is basically because we had 5 randomly selected communities, and there is a bunch of other communities that we didn't select. And so he's trying to exploit, basically compare these who we visited and did not visit. So for the sake of time.
Just a very quick question.
Sure.
Out of curiosity, is there any overlapping between your clinics and the ones included in the QJE paper by Christensen and co-authors?
Sorry, which paper? I didn't quite hear it. Say it again. Sorry, can you come again?
The one which just came out on QJE about
the one by
resilient health systems.
Oh, Andrea Dubé and you mean by Andrea and Bilal? Andrea Dubé and Bilal Siddiqui and Johannes Haushofer, the one on the.
And yeah, the first author I think is Christensen, but yeah, Johannes also.
Oh yeah, sorry, I didn't know. Sorry. Yeah. You mean the one on the community health worker intervention and then what happens
accountability.
Yeah. Our districts are Bombardee, Tonkolili, Cambia, and Western. I don't know what their districts were. Actually, I wasn't RA on that project. Good question. I don't remember being in these districts. I remember being in Kono and Port Loko back then, but I will check. But what I should just be clear on, when we did the original clinic selection, we did ask, so we had these 4 districts. There was a sample of over 322 clinics, I believe. We did check in if there are predominantly already NGOs working that are doing such as food distribution programs, or are there any systematic heavy programs on incentives? And there were some chiefdoms that we excluded, not clinics, but entire chiefdoms. There's nothing that I was aware of that is ongoingly happening in terms of major programs that we're working in. And we have collected data on, so I guess what I'm trying to get at right now, what you're asking me is, if there's anything different about the supply side or potentially even in terms of trust from community members of coming to the clinic. We don't observe anything in observable data that we have from the supply side, also on any incentives or any structures in the clinic. And we also have some data on baseline behavior, pre-trans, and we don't see any differences in these clinics when it comes to pre-transfer immunizations. I guess that's what I can say right now in order to address that point. It could be that there were some, but then not something that I could tangibly know. I would worry about some sort of systematic differences in my clinics across different arms. If you had anything else in mind, then please let me know.
No, it was just that. Thanks.
Okay. Yeah, not that I know of, but it's a good question. Ondrola has not mentioned it to me yet, although I guess I should talk to her about it. Okay. So the interim intervention, even though this is it's the real world, it's really messy. I can say it was properly implemented. I'm showing you this here. If you just draw attention to the bottom left, and I'm plotting there the 5 vaccines. It says signal at 4 on top. What you kind of see is for the first, second, and third vaccine, you see a lot of yellow and you see no green. What that basically means, we went into communities and asked babies that were at a certain vaccine stage what bracelet you have. And you can see in the signal at 4, as it should be, there were almost no babies that had a green bracelet that were accidentally given one at the time of the second or the third vaccine. But what you see is this continuous jump up of an increase of about 60 percentage points of the likelihood that you have a green when you're at the 4th and 5th vaccine. The reason why you still have some yellow there, to be clear, is because we didn't allow babies to get the bracelets if they were more than 2.5 months late for a vaccine. So this is a mix of babies coming very late for that specific vaccine, and there's also some implementation error. But overall, you can see in these 2 bottom graphs, the signal at 4 and 5, you see the implementation took very well the first stage, in the sense that green happens when green should happen and not before. And you also don't see a significant difference at the green bar for the 4th vaccine and 5th vaccine at signal at 4. So meaning it was not the case that people were more likely to get the green at the 5th in signal at 4, which it shouldn't. It should be uninformative whether you had the 5th in the signal at 4 treatment. So let me go into the results because we are going to run out of time. So I'm first going to talk about the mechanism. So just to be clear what I mean by the mechanism is tracing out that sort of chain that we need in order to think about social image concerns. So the first step we need is that people draw inferences about parents' immunization decisions by observing the signals. So what does that mean? The probability that someone assigns to your child having received a certain vaccine conditional on observing a green bracelet has to be different than the probability the person assigns to you having received a certain vaccine conditional on observing you with a yellow bracelet. So this first stage is we need a wedge needs to open up in terms of the probabilities others assign for your actions. And then the second stage is that conditional on that, they need to assign different type expectations. So the very first part, which no one has asked yet, but it sort of relates to the fundamentals as well. None of this work would actually be in any way relevant if there weren't any information asymmetries existing. So I wasn't able as a PhD student to do a belief survey at baseline, but I can tell you about data of the control group at endline. And in the control group at endline, it is the case that mothers believe that only 48% of other mothers in their community know the number of vaccines that their child received. So there's still plenty of scope basically to reduce information asymmetries in terms of increasing the believed knowledge that other people have about my own decisions. Secondly, you're thinking about, well, did these bracelets actually work? Were they out? Were they worn? I can tell you that 90% of endline respondents report to know if another child has a bracelet in their community. And also to know, so it's conditionally 87% of those also said that they know that because they saw the child with the bracelet. So it's not just what we would worry about, the baby has a certain age and therefore it should have a bracelet. So more specifically, I don't have it on the slide, but over 90% of the 91% also knew the color of the bracelet. So there seems to be very high visibility. Yes?
I'm sorry, just real quick. I think you already answered this, but just to clarify, you don't ask people who exactly is a bad parent, right?
No.
Okay.
So we try to do no, we don't ask that question. We don't ask who's the bad parent or something. I tried to implement a lab in the field game with assigning mangoes or something at some point, but I wasn't really confident in any of the stuff. And honestly, I have huge respect for anyone who pulls off. I mean, I have a very illiterate population as well. I'm not saying they can't, this is not possible, but doing any more sophisticated things where you measure these kind of things in the lab. So we're really working with straightforward, or not straightforward, most of these belief questions were piloted for a year, but belief questions and sort of what do you know, preference questions, and so on.
Right. So we don't know. So we don't know if the people who actually don't vaccinate their kids are the ones who their peers believe don't vaccinate their kids. This we don't know.
No, we don't know that for the belief data.
Really? So
we
like,
do know about the information asymmetries. What you're asking me is the judgment. And
what I'm asking
in terms
is,
of like, you're asking me, would they say one conditional on knowing or conditional on believing to know that you haven't come for a vaccine, do I think you're a bad parent? Is that correct?
Exactly. Yeah.
Yeah.
Like,
No, I don't have that last step.
Okay.
And also, to be quite clear, I mean, we're trying to get at this now as I'm quantifying welfare. So we're going back in the field and trying to do this more, because all I'm implementing right now is just a general question. How would community members view you if you took your child for all vaccinations, or if you missed to take your child vaccinations? So these are basically this perceived social judgments that people would say, and this was a question that was free text. There was no, pre-given answer set. So anything literally just asking, how do you think other community members would view you? And what you can see here in these two questions, there's two very large blue bars. If anyone wants to try to add up these numbers, they're not going to add up to 100% because you could give multiple answers. But you can see that 92% of people would say, if I took my child for all vaccines, people would consider me something along the line of caring, patient, serious, loving parent. And if I didn't do that, I would be considered as careless. It is true that it's a completely empirical question how these social image concerns manifest itself. And it could have been the case that actually the judgment that is formed is more about you're poor, right? Or you're lazy, or you're ignorant, right? And so what I believe this data is showing, though not individually for every single parent in the community, is that the predominant image concerns that people are reporting is about what type of parent you are, as opposed to saying, oh, people would think I'm ignorant, or people think I'm lazy, or, I don't know of the importance.
Yeah. No, I think it's fantastic. It's very good.
No, but I agree with you. It's just, and also to be clear, I'm very interested, anyone can email me. I think it's very difficult to not prime. And I'm always nervous about priming people to say something. And the other thing I'm very difficult is that, you might judge Katya if she's not going to get the COVID vaccine. Would you say Katya is therefore a bad person? So there's obviously a confluence of factors. I mean, you need to then really parse that out in a specific area, right? In terms of like, you might negatively think about her, but you wouldn't necessarily she's a bad person, right? Or you may not punish her directly.
Never.
Right, and so what I mean, but a lot of the stuff is really implicit, right? Even amongst anonymous people like Stefano Della Vigna's work on voting, right? It's not even is an anonymous person about whether they know that you didn't vote. You have no repeated interaction with that person even, and still social image concerns can move you. So I think, anyways, I think there is method stuff right now. Dmitry Dubinsky and co-authors have a new paper on that, and I'm trying to implement that into the field to get at these sort of social welfare concerns or social stigma and social stigma or reward. But it wasn't straightforward to me to implement a question, to be honest, on that. So let me just show you. So I think one of the main graphs here, and then I really want to jump to the main results, and then we're soon done. Sorry, that's a rush for this. So one of the main questions I'm using in this paper is very straightforward. Do parents? So we want to ask, do parents update their beliefs conditional on the signals they observe? So the object we're interested in is the probability of having a certain vaccine conditional on the color. And at the end line, we asked each parent that we surveyed about a random subset of other parents in their community, and conditional on knowing that person, I mean, they at least have to know them, who they are. We asked them, how many vaccines do you think this child has received, and what color bracelet does this child have? So this gives me this pair that allows me to compute overall then, like for each of the bracelet arms, how do people relate color and the probability that a child has received a certain vaccine? So what I'm plotting here is I'm showing you on the x-axis, I'm showing you for vaccine 3, 4, and 5. I'm showing you each of the bracelet treatments. So the uninformative, signal at 4 and signal at 5. And on the y-axis, I'm plotting the probability that a child would have a certain vaccine conditional on either yellow or green. So if you just pay attention to vaccine 3 and you look at the UI column, then what you see is that generally there's a very high probability that people assign to a child having received vaccine 3, assuming the child is in that appropriate age range. It's always by appropriate age range. But there's no significant difference in terms of the probability they assign the child has this vaccine depending on yellow or green. The same applies if you move to vaccine 4 and you look at UI again. You see that the yellow and the green bars are almost, perfectly overlapping, meaning there is no inference by color on what number of vaccine a child has received or not. For vaccine 5, you see a small difference. To be clear, I'm having much less sample there. The difference is not significant in a statistical sense, but I'm having less sample there simply because fewer babies were as old to be eligible for the 5th vaccine, because it takes a year. And so, I couldn't run that experiment forever because I had to graduate at some point, but the difference is not significant. So again, in all 3 columns for UI, there's no significant difference between yellow or green, meaning the probability people would assign to a child having a specific vaccine conditional on color. When you focus your attention now on S4 and S5, and I'm indicating that also on top, the difference, I'm showing you the difference between the yellow and green on top of it, and then the significance level, we can see there is a clear wedge opening up in terms of the likelihood a respondent assigned to a child having a specific vaccine conditional on green versus yellow. And interesting as well, the informative content, how informative the yellow or green bracelet were, is the same for the signal 4 as also the signal 5. Like, I can't reject the difference actually, although you could talk about power between signal 4 and 5 for the 5th vaccine. So overall, both of these bracelets, from what we see in the data, were very informative in terms of making people believe that a child is more likely to have the 4th or the 5th vaccine if they have a green versus a yellow bracelet. So this is the first stage. Now the second part is, or first stage was sort of the implementation, but like the first stage in terms of mechanism, what we want to learn. Now we just already talked about what Wayne asked in terms of social judgment. I've provided you some data on evidence on how people, what social judgments they're actually forming. And now I'm going to jump to the main results. So basically we verified these 2 mechanism steps. And the real question is now, well, are these preferences then strong enough such that this wedge that seemingly has opened up in terms of probabilities that people assign to certain actions and then the judgments they attach to those actually meaningfully influence immunization behavior. So we're interested now in how strong are these preferences, which is the combine of the social image parameter as well as the valuation for that specific action to signal that I'm a higher or lower type. So what I'm doing is I'm taking the data that I've already described to you from the listing survey, I'm complementing it with some administrative data because I implemented the listing before the experiment was fully over, and so I couldn't observe all babies towards the end. So we complemented with administrative data just to address your concern. We did a lot of quality checks. There is no differential quality in the recording of administrative data from the nurses based on the treatment arm. One could worry about that, obviously, if they just felt they need to report more babies in measles vaccines or vaccine 4 because we now implement these bracelets. So this is a check we conducted. There's no significant differences. So what I'm going to be showing you on the following is the same type of graph we're going to seen before. We're going to look at the share of children that received a given number of vaccines on time and just going to regress that on the treatment indicators. I'm controlling, or I'm accounting for the stratification. And I'm also controlling for a set of controls, which is child age, distance to the clinic, and community population size. Those are the controls that are included. So let me first show you the results of the trial. When I'm getting tired, sometimes my language is, so the experiment. Let me show you the results of combined, first of all, the signal at 4 and 5 compared to the control group. So what you're seeing here again is same as before. I'm plotting you on the x-axis the 5 vaccines, on the y-axis the share of children that received a specific vaccine. In gray, underlyingly in the graph, you see the control levels, which fall from 96% of children getting vaccinated for vaccine 1 down to 55% for vaccine 5. And I'm overlaying what are the effects for signal 4 and 5, so the levels, and then I'm showing you indicated on the side the treatment effects. So if you look at vaccine 5, you can see that the combined effect of signal 4 and 5 is roughly an increase of 8 percentage points in terms of take up of the last vaccine. Or to be clear, timely taking up all of these vaccines, so making it the last vaccine. We're seeing similarly in treatment effect of about 7.5 percentage points for the 4th vaccine. Now, the interesting part though is, so overall, both signals had an effect, signaling moved immunization rates on those margins where we introduced the signal. The interesting part though is there's significant heterogeneity in this treatment effect as we're separating out these 2 different treatments. So when comparing just the signaling at 4 compared to the control arm, we actually find no significant differences in terms of immunization levels. You see it's very noisy, but it's only about 2-3 percentage points of movement that I see. And all the movement essentially is coming from the signal at 5. So when you look at the last vaccine here, we're seeing an increase from 56% up to 70% in terms of take up for that last vaccine. But interestingly, thinking back to the predictions that we had also from the theory, there's not only a significant increase on the margin where they could signal, but similarly for vaccine 4, 3, and 2, we see significant increases in the probability that parents would have taken their children for these vaccines and even on time. But importantly as well, people who might be more likely to come for the second vaccine or third vaccine right now, we can also see them not making it all the way to the end, right? There's still basically that dropout pattern that people would get stuck before they're actually making it to the signaling margin. So these kind of treatment effects would not be one that we could reconcile in some sense under a model of perfect information where everyone knew exactly what the world would look like in 9 months, but are some that are perfectly reconcilable once we allow a social signaling model to introduce some uncertainty and people basically act upon the option value of the future having this opportunity to signal, but they also know they're going to learn in each period what specific shocks they're going to experience. And leaving research aside, but just thinking about policy, these are meaningful impacts. So the vaccine 4, as we talked about before, is this bundle of 3, where they're basically completing all 3 doses. We're increasing immunization rates for diphtheria up to 84%, which is reaching herd immunity levels for this type of disease. So then lastly, I was a bit cheeky. I compared it to the control level. So looking at the impacts of the uninformative bracelet, we're observing similarly small effects and very noisy. There is a slightly stronger effect on the last vaccine, although very noisy. This has something to do with the fact that when we look at treatment effects over time, so bear with me for a moment, but what I'm showing you here is essentially these treatment effects for different birth cohorts. So the gray line is the time when the experiment was phased in. And then I'm showing you the average treatment effects to the right of the gray line for each subsequent birth cohort of children. So it's the average treatment effect of signal at 5, signal at 4, and also the uninformative bracelet, so compared to the control. And what you can see here in the blue line, where I'm plotting you the average treatment effect of the uninformative bracelet, we did initially have quite a bit of movement. So it seems like at the beginning, initially, there was quite a bit of take-up, shift in basically for this uninformative bracelet. Importantly, though, and this I think speaks sort of to what Pedro was asking, when we're looking at the red line, which is the average treatment effect for the signal at 5, I don't see any significant differences across time. I didn't plot confidence intervals or tests more here to make this plot not too noisy, but there's no significant differences in treatment effects across the different cohorts, but it's fairly stable. Future research, which we're now having in the field, will extend this plot 3 years out, and I'll be able to tell you what happened once we stopped the experiment or was only partially implemented, what essentially happened to immunization rates. Also, to be clear, even when you compare the uninformative bracelet to the signal at 5 bracelets, the magnitude of the effects goes slightly down, but they are remaining significant at around 10-9 percentage points, and even for earlier vaccines at around 5.2 percentage points. So then lastly, I think the elephant in the room is really why did one signal work and why did another signal not work, right? Why do we mean we have to be careful from a policy, when we're thinking about interventions and how we design them, why do we may have to be careful at what margins we're introducing vaccines if it's just a vaccine? I mean, who cares what vaccine? Why is there a difference? And so what we're asking at Endline is, which vaccine do you consider to be the most important for your child, and what vaccine do you consider to be the second most important for your child? And what you can see when you look on the left side, the most important vaccine for most people is the first vaccine. So they think, which makes sense, after birth, the baby is fragile. That's what they would often say. The first vaccine is really important. And then people sort of shift towards the 5th vaccine or all vaccines. When moving to the second vaccine, what we see, if you look at the right side, the light blue, you see that the second vaccine is considered as now most important. And then again, more weight is shifted to vaccine 5 for all vaccines. So overall, if you were to rank the vaccines in people's minds in terms of most the second important vaccines, there's a pattern that emerges where the first and second vaccine, but really the 5th vaccine is the second most important vaccine considered. And there is a missing mass when thinking about vaccine 3 and 4. Vaccine 4 is actually the one that is considered as least important, as being also the third in a series of 3. So I think this causes in some sense, if there isn't, oh yes, please.
Sorry, yeah, if I just a clarification question to be sure I follow about which vaccine is what. I thought the second, third, and fifth were this coronavirus type vaccine, where you either do them all or they're useless. The vaccine 224, was it repetition of the same vaccine?
Yes, correct. Vaccine
so it's
2, 3,
incorrect
and 4.
beliefs that you're presenting in this slide, if I understood well, just to.
Yeah, so sorry, I'm not, sorry, I have a bit of a problem just from audio, not that you don't explain it well, just I don't hear it quite well. So to be clear, the vaccine 2, 3, and 4 are the ones that are the same vaccines. It's just 3 doses of the same vaccine.
Okay.
And vaccine 5 is a distinct vaccine.
Okay, just to be sure then, how to reconcile that with the idea that the second vaccine is the most important?
Because they're thinking in
incorrect
terms of
belief, or why?
Oh no, it's actually correct. So remarkably speaking, so not remarkably, but it's actually quite remarkable. I mean, remarkable in the sense that most of us have very poor knowledge of specific vaccines or these type of health interventions. And if you're not very well educated, you may even have less knowledge, you would think. And, you know, over 50% of individuals in my sample have no primary education. So it is, however, true from a health benefit point that the first immunization and the first doses in this sequence of 3 and the second doses are sufficient for most children to have built up the immunity to protect them from these diseases. So I mean, we have not the best data on this in terms of like actually telling exactly the shape, the functional form of the buildup of immunity, but the majority of children reach that with the first 2 doses. The third doses, however, is necessary in order for us to cover sort of the remaining set of children that haven't quite reached it and to reach herd immunity. So from a private point, an expectation, the third doses is not as helpful for you. But from a social point, the third doses is really important because we're going to reach herd immunity levels to that, because all the people, like we need over 90% for most of these diseases in terms of take-up levels to be covered and protected from these diseases. So they're thinking as such is not wrong in terms of that there is a difference between the different visits. It's kind of similar what we now know about the Pfizer as well, although it's even starker. The first vaccine apparently already gives you 92% protection, which we may or may not have wanted to share with the public. I mean, in terms of incentives of coming for the second doses. But yes, it's not a linear function in terms of build-up of immunity across these 3 vaccines. Does that make sense? Or does this reconcile sort of address the concern?
Sorry, yeah, it does. It was just to understand like about this idea of importance of the vaccine, what it was bringing.
Yeah. So they're not the same vaccines. They're distinguishing between the different visits. So then, for the sake of time, and just to be clear as well, there is another caveat that I can say if we're going into the depths of the paper, but it is about, I had shown you in the informativeness that the signal 4 also carries some information about having come from vaccine 5. However, when we're comparing just sheer how informative signal 4 is about completing vaccine 5 versus how informative signal 5 is about completing vaccine 5, then it is true that still the informativeness of the signal at 4 is not strong enough, or is at such level that we can reconcile why signal at 4 may have a weaker effect. I think the main takeaway, as I'm running a little bit out of time here as well, is that it really matters in terms of thinking about what are perceptions about the importance of certain actions, and therefore obviously how I'm going to be judged, how these actions are going to be socially useful for me to be considered a good or bad person when thinking about where to attach signals. But also what can be done, what we've seen in the results here, is I can introduce a signal for an action that might be highly valuable in order for me to signal I'm of a higher type, like a good parent, and it may move people even to do an action that they otherwise wouldn't care as much about, which is coming for this 4th vaccine. Since we don't only observe treatment effects from the last vaccine, but we're observing a general shift in the distribution. So we even basically reached herd immunity levels for one of the diseases on the 4th vaccine visit. Then lastly, so I think I've already told you everything that is on the slide. I think because I don't have much time and I want to leave a little bit more for questions, I just want to give you a flavor of how I thought in this paper on thinking about pricing out social signaling. So I'm showing you here 4 different graphs, one for each vaccine, where I'm plotting now on the x-axis the distance to the clinic. So what you see for each vaccine, the distance to the clinic could have been between 0 to 5 miles. And on the y-axis, I'm plotting the take-up level. In blue, you see the control take-up, and in red, you see the take-up for signal at 5. So a simple thought experiment that we can do here is if you were shift your attention to vaccine 4, please, the lower graph. We could either say we're going to move a parent to 0 mile distance, so we give them a travel voucher, for example, and say, or we move their house, and say you're at 0 distance to the clinic. Or alternatively, if you were to draw just a horizontal line over, we could basically move you at 4 mile distance and give you a signal, basically give you the opportunity to signal. And you see that sort of in each of these graphs, that it's about equivalent for each of, the signaling treatment is about equivalent saying I move you to 0 miles distance versus I leave you at 4 mile distance from the clinic, but I give you the opportunity to signal. And so the additional work that I'm doing here, obviously there is selection in each of these graphs. The population of types that we're observing in each of these vaccine decisions is different. And we also need to think about what are the expectations that people forward-lookingly form of making it to the next vaccine and to the signaling margin. So I'm using a discrete choice model, which is something that's normally used in the education literature when thinking about making the decision to stay in school or drop out of school and the educational returns or labor market returns. And I'm using the experimental variation that I introduced, as well as that I observe people making them repeatedly make decisions in order to be able to estimate the type distribution, but also in order to estimate the parameter on the social signaling term. And then what I'm doing is I'm estimating the marginal disutility of walking and the utility from signaling. And I'm going to be able to take the ratio of those. That's what I'm basically doing in order to price out the signaling utility in terms of miles walking to the clinic. And so for the control group, that is approximately 7.7 miles. And for the uninformative group, if we were to compare signal 5 to the uninformative, it's about 4.75 miles. So I think I made a typo, not a typo, I misspoke in the first slide. I'm going to correct myself now. The difference is between the evaluations between 5 to 8 miles walking distance. So if you were to be the average person, which is located at 2 miles distance, then this experiment would encourage you, or your willingness would be on average to walk about 2 to 4 additional vaccines, an expectation. So to conclude, because I'm really out of time, and we have 5 more minutes, I think, for questions. And linking back to how we started this off, social signals built on existing norms, as I'm showing in this paper here, can significantly affect parents' decisions to vaccinate their child. The effects, however, vary strongly with the social desirability of the action that we're allowing people to show. Importantly as well, signals can motivate individuals to change their behavior far in advance. So we're observing changes in decisions to vaccinate for parents that make a decision for a child at 1 or 2 months age, when actually the signaling return is only appearing at 9 or 10 months age for the child. Overall, this is a very low-cost intervention to any existing interventions in the space. On incentives, this costs about 0.8, so 88 cents per child, the spray-set intervention costs. And I have complementary research that also shows similar effects in the context of deworming. And I think just one other thing I wanted to say, going back, this graph, I showed you aggregate preferences, essentially because at end line, there was no difference across arms. So there's a table for this in the paper, but it's not just imprecisely estimated. You can look at the coefficients. There's no significant differences at all, not a magnitude, not a significance in terms of people's perceptions at end line after this experiment ended, in terms of what they perceive to be the most important vaccine or the second or third most second most important vaccine. Okay, thank you so much.
Great, thank you, Anne. Really illuminating research. I think, as you mentioned, we've got time for maybe one question or possibly 2 really quick ones if anyone has a question that they want to ask.
Please.
Maybe just a quick question. And so, do you have a sense of about whether there are impacts on the use of these clinics outside vaccination. So, could it be that this is crowding out other efforts, or on the opposite direction, it is actually getting people closer to the clinics?
Yes, so I did not have all these illuminating thoughts when I implemented my PhD research, and I also didn't have the money to collect all the data. But we're currently collecting data on vitamin A visits and deworming, which are two very important childhood, treatments. And these are actually adjacent visits that are right in between the vaccines or after a vaccine. And we're also collecting data on a vaccine that was not incentivized, which is now at 15 months. So these questions in terms of substitution or complementarities or just completely independent, I'll be able to answer in 6 months. The data is collected in about 3 months. So hopefully in 6 months, if I'm being overly optimistic. So I can't say anything to this right now, but I'll be able to speak to this before the end of the year.
Very cool.
Thank you.
Okay. Well, if there's no other questions, I realize we're out of time. So we'll just thank you, Anne, so much. Very fascinating and thoughtful research, and we're really happy that you've come to visit us, and hope to see you again in the future.
Yeah, I hope to visit. I had so many
much.
great meetings today. I had a really great day. So hope to see
you very much,
you again. Thanks so much. Bye. Bye.
Bye-bye.
Thanks, Anne.
Bye.
Bye-bye.
Bye. Bye.